presenter. Thank you. So that we just allow the presenter's mic to be on so that we do not disturb the presenter with feedback and all. Let's, again, we can write our questions in the chat or we can write them, keep them somewhere safe, then we can ask the questions at the end of the presentation. So the meeting is being recorded. Those who have questions or the discussion, we can always have a discussion at the end and address all the questions and contributions and additions. So our presenter tonight is once again, hey, let me not say your name. Last time I think I didn't say it well. So I think it's not his first time to present. Last time we had a good presentation. So I think let me hand over to you. Please say your name again nicely so that we can all get to know it again. Thank you.
Okay, thank you, Mr. Sambi. My name is Tewodros Amde, and first of all, it's my pleasure to present in Radiology Without Borders webinar for the second time. And let me tell you about my background. Medical radiological technologist in Menilik Secondary Medical and Health Science College. And I am one of the pioneer 6 students who graduated in Masters of MRT in Ethiopia. So with that being said, I think it's time to proceed into our presentation. Right, Mr. Hambi?
Yes, please go ahead.
Okay. Thank you so much. Today, we're going to see the most controversial topics in the realm of ultrasound diagnosis, and that is fetal growth restriction. So, what is the importance of this webinar, or what's the importance of creating an awareness for IUGR, for radiologists and medical radiologist technologists about IUGR? Because it's a major factor in preventing stillbirth, and it's the norm in our setting to see a fetus, which is normal, but that normal fetus may appear FGR at the end of the day. So we may fail to diagnose those FGR patients which may look like a normal. The other thing is even the fetus delivered well, even the fetus is delivered well without any complication, if the FGR is masking within the fetus, we may end with...
Okay, thank you. It's fine, continue.
Is that working?
Yes, now we can hear you again.
Okay, so if the fetus is abnormally, or if there is a masking of FGR with that normal looking fetus, and if it delivered normally, so that fetus may develop consequential neurological and other problems even after delivery. So that's the most important thing is to discuss about the FGR diagnosis in prenatal period by ultrasound. So for the time being, let's arbitrarily define what IUGR means. So without considering any clinical data, without considering any ultrasound specific parameters or things, let's generally or arbitrarily define what IUGR means. IUGR is defined as a rate of fetal growth that's below the normal growth potential. This is just an arbitrary definition of IUGR fetus. So what are the etiologies and risk factors for IUGR? There are maternal risk factor, placental risk factor, and fetal risk factor, as well as there are some exogenous risk factors which may predispose the fetus to become growth restricted. The first thing is hypertension in the maternal growth factors. So what hypertension does to the fetus is there is a link, there is an association between hypertension, especially preeclampsia and eclampsia, and the alteration of the spiral arteries or the placenta of the mother, the placenta. So what hypertension or preeclampsia can do to this fetal-maternal problem, it's closely linked to a maladaptation of the spiral arteries. So the spiral arteries do not convolute, do not straighten up, do not become wide in diameter. So that may predispose a malnourishment of the placenta, which eventually restrict the fetus at hand. The other thing is diabetes mellitus. As we all know, diabetes mellitus is strongly associated with large for gestational age, but it could also cause fetal growth restriction. Because diabetes mellitus is strongly associated with microvasculature of vessels. So if there is a vessel that becomes small in diameter due to the DM, so it could predispose the patient, the fetus, getting adequate nutrients. The other thing is obesity and maternal factor, and the placental factors are placental insufficiency. Those cases, the hypertension case or the DM may predispose the placenta to become insufficient, which means it can't feed the baby with adequate nutrition and oxygen. This could be due to vascular maladaptation or endothelial malfunction or unconvoluted of unstraightened up of spiral arteries and the like. There are also other abnormalities of the placenta which may predispose the fetus to be growth restricted. For example, if there is any myoma, if there is any placental-associated mass like chorioangioma, if there is such kinds of abnormality, it also predisposes the fetus to become growthly restricted. The fetal factors are aneuploidy, structural abnormality, and fetal syndrome. The other thing that we're going to suggest for exogenous factors are smoking and infection. So there are two important chemicals when we talk about the smoking. The first thing is the carbon monoxide, and the other thing is the nicotine. So what do those two chemicals do for the fetal maternal circulation is, well, nicotine will make the chorionic villi to decrease in surface area. So if there is a decrease in surface area, that will predispose again to become low in nutrient and oxygen delivery for the fetus. And the other thing is carbon monoxide, which is apparent in cigarettes. So carbon monoxide is highly competent with oxygen in transport to the bloodstream by hemoglobin. So the carbon monoxide will compete for oxygen. So there will be a lack of oxygen for the fetus to be fed on. So those are the etiology and risk factors which predispose the fetus to be growth restricted. So generally, when we talk about fetal growth restriction, we have to take care with words. Words will matter when we talk, when we write a report about fetal growth restriction. So let us clear them out. The first thing is fetal size and fetal growth. So there is a difference between fetal size and fetal growth. Fetal size is the biometric measurement of the fetus, and it's determined at a point of time by using those indicator measurements here. So another thing that could tell us about the fetal size is the estimated fetal weight. The most important thing here is we can identify the fetal size to be below the average or above the average at a single point of time without considering another scanning time, okay? So that is what we call fetal size. We can also determine the fetal size only by measuring those biometric parameters indicated here. But when you talk about fetal growth, it is a hypothetical situation, the dynamic process. So its assessment requires multiple observations of the fetal size over time. It means you can see, you are scanning the patient by ultrasound and you measure the HC, BPD, FL, and you see the deviations of those parameters from the established gestational age. Then you can call that fetal is growth restricted without considering either another parameters or consequential ultrasound, consequtive ultrasound exam. That's the difference between fetal size and fetal growth. But at the point of time when we do a single ultrasound parameter, a single ultrasound scan, you can tell about the fetal size at that point of time. So the difference of those words is clear, I think. So it's time to move to become serious and to become to define what the exact definition of small for gestational age versus fetal growth restriction. So in clinical medicine, definition matters. So international guideline like ISOP and DAJO defined SGA and FGR accordingly, and we are going to see how they define it. As I told you before, small for gestational age is talking all about the fetal size. So if the fetal size is below the predetermined threshold for its gestational age, which means below 10 percentile is the estimated fetal weight, and if the abdominal circumference is below the 10 percentile, we can call that fetus small for gestational age. The second thing is fetal growth restriction. Growth is hypothetical. Growth is difficult to determine in single ultrasound parameter. So the definition is also confusing or arbitrary. But the most plausible definition that I'm going to present for you about FGR is it's defined as a fetus failing to reach its genetically predetermined growth potential. Here, genetically predetermined is highlighted because that fetus, due to her father or her mother condition, that fetus has the genetically predetermined size, genetically predetermined growth. So if that fetus is failing to reach that genetically predetermined growth potential, we can call it FGR. That's why ultrasound diagnosis of FGR is so much difficult as compared to ultrasound diagnosis of more for gestational age. This is the most important diagram here, and the majority of the populations are appropriate for gestational age. And here you can see small portion of the populations is SGA. Now, you may recall that I might miss large for gestational age. It's on purpose, and our focus here is to deal with the growth restricted baby. So I omitted that for simplicity of illustration. But the most important question that must be asked on this diagram is the growth restricted triangle has covered the appropriate gestational age fetus. That's true, brothers and sisters. Growth normal for gestational age fetus or a gestational a fetus who has above 10 percentile for an established gestational age could also be growth restricted, which means you may see a photo of tiger and you expected that tiger to run as hell, but when he ran, it becomes low. So eventually that photo of tiger is a cat. It's masking on normal for gestational age fetus. So when you do an examinations of growth restricted fetus, you must also consider that growth restricted fetus are not only on the subset of small for gestational age, but also appropriate for gestational age fetus could possibly develop fetus growth restriction, which is masked under their gene. It may be late onset FGR, it may be early onset FGR, but we have to know that appropriate for gestational fetuses or fetuses above the 10 percentile could possibly develop growth restriction. So let's get into practice. First of all, before you do any ultrasound diagnosis for fetal growth restriction, we have to, or small for gestational age, we have to establish the normal or the exact gestational age of the fetus. That is the pivotal point in ultrasound diagnosis of FGR. So as you can see here, there are different types of fetal age. The first thing would be conceptual age. The second is biometric age and menstruational. Conceptual age is exactly, in the conceptual age, we can exactly know the fetus's age because in vivo or in vitro fertilization, so we know the exact time, the exact date of the fetus, so it doesn't matter. Biometric age is what we found on the average ultrasound calculations of our machine. And the other thing is menstrual age, which takes account of the last menstruational periods of the mother. So again, reference gestational age is pivotal for IUGR diagnosis. We have to establish the exact gestational age of the fetus to diagnose FGR. So how do we establish those gestational ages? We have three options. The first one is the first trimester ultrasound report by CRL, the paramount important. It's best to get the first trimester ultrasound report, and is found to be more reliable and more exact in defining the exact gestational age of the fetus, even more than LNP and other traditional parameters. The second thing is we have to obtain a reliable last menstruational periods of the mother, but it's more difficult to obtain the exact dates by using LNP because a lot of mothers may not unable to recall their LNP, and those LNP measurements are also affected by menstruational irregularities or other myomas involving in the uterus. So it's really difficult to get the real LNP of the fetus due by LNP. So what we're gonna do is obtain the LNP from her mothers. So compare it with the first trimester ultrasound. If there is a 5-day gap between those first trimester and reliable LNP, you can take a reliable LNP as an established standard. The third one is transcerebral diameter. If the fetus is growing and in the late second trimester, so transcerebral diameter could also help. Why? Because the fetal cerebellum is the least organ to be affected by growth restriction. But a lot of literatures also say that transcerebral diameter could be affected by nutrition status, or other maternal conditions. So again, it's not that much reliable in established gestational age, but rather practically in my setting, I use transcerebral diameter to confirm those established gestational ages which were established by first trimester ultrasound or reliable LMP periods. So we found those numbers, and as I told you before, it is the most important thing. If you don't obtain an accurate gestational age, If you don't obtain the exact gestational of the fetus, you might be mistaken in diagnosis of small for gestational age and FGR, as well as other Doppler parameters, because those parameters can be compared by using reference standards of those three established gestational ages. Okay, so the work is not stopping by only obtaining those reliable gestational ages. You have to dig the accuracy of those gestational ages by using other traditional measurements, like I do on transcerebral diameter. The most important traditional measurement, especially in the third trimester, is to see the visibility of the distal femoral epiphysis. So scholars suggest that if you see the distal femoral epiphysis, and if it measure 1 up to 2 centimeters in the longest diameter and the longest measurement, then that fetus or the population, 87% population of the fetus are on 33 weeks and onward. If it measure 3 millimeter, so that fetus could lie between 36 and 37 weeks of gestationality. It's not inaccurate, but it helps you to make sure that the gestational age obtained from the first trimester ultrasound and from the reliable NAP is accurate. The other thing, apart from the distal femoral epiphysis, is the proximal tibial epiphysis. So the proximal tibial epiphysis is visible beyond 34 weeks and above. So if you don't see any tibial epiphysis, you have to consider that the fetus is below 34 weeks, and it's evidenced by a lot of meta-analysis, and it is evidenced by a lot of journals. Okay. The other thing that you have to be sure in determining the first trimester ultrasound report and reliable NBP, LNP is when you find the proximal tibial epiphysis, and if the gestational age is below 39, you have to recheck those first trimester ultrasound and reliable NAP, because in 39 weeks, 100% of the fetus do have, or it is visible, the proximal tibial epiphysis is visible on ultrasound in 100% of the fetus, and it's confirmed by a lot of meta-analysis and a lot of scholars. Okay, so in Ethiopia, there is an application which was created by Paulos in collaboration with Paulos and Ethiopian Health Minister, I think. So what they do is they provide us the calculation in mobile applications, which shows, sorry, which shows there is a slot to enter the date and the day and the calendar, and it will, the gestational age at the present day will be displayed here. And I know there is a lot of calculators on web, but the main important of this calculator, and I like most about this calculator, is it display those antenatal visits here. What would be her visit in 36 weeks, and the difference between those 2 weeks, and the difference between 30 up to 40 is 4 weeks. So if the patient tells you the LNP, you will fill the LNP here, and you will reconfirm the gestational age. You will confirm her appointment dates. For example, did you come on June 20? You say yes, okay, that's one confirmation, and then you'll ask again if she comes on June 6. Say yes, oh, you confirm that gestational age, and the health center or the hospital were established those gestational ages by LNP. So that is an exact date. You do have a full confidence. So you move forward in diagnosis of LNP. And this calculator also included the manipulation by using the first trimester ultrasound, as you can see here, and it displays again all the visits in the days, which will help you for reconfirm those gestational age. So as you can see, I spent a lot of time in discussing about getting an accurate gestational age of the fetus in diagnosing a UGR because it's the most important parameter. If you miss on this step, then everything that we are going to talk onward will be a misdiagnosis. See, if you don't get an exact gestational age, everything is nothing, okay? So from now on on our webinar, we will assume that the pregnancy is singleton and the pregnancy dating has been established correctly, preferably by first trimester ultrasound. And ESOP is the recommended first trimester ultrasound as an establishment for exact gestational. Then what you're going to do is doing an ultrasound measurement, which is an ultrasound biometry that include BPD, HC, AC, and FL. I know that most of the participants of these webinars are experts. I'm not here to discuss how to measure BPD, AC, and it's beyond our topic. So, but I really want to emphasize that when you measure HC and AC, the caliber should be placed in outer to outer position. That is the most important thing, and it increases its reliability. Okay. The second thing that I want to highlight is most of the ultrasound, even the all ultrasounds, have a toolkit to measure those ellipses. The first one is the ellipse tool, and the second one is a 2-diameter method. A lot of guidelines, ESOP, Azure, and others recommended the ellipse tool to be measured for those HC and AC, and we consider that. I know that a lot of latest, which means beyond 2020 machines, also have an AI tool to measure those parameters, and researchers are ongoing in evaluating the accuracy, the reliability of those AI parameters, the reproducibility of those AI parameters, and there is no universal consensus on using those AI parameters. So for now on, I will emphasize more on using this tool for measuring HC and AC. The other thing, when you measure all those parameters, the estimated fetal weight will be pop out, but what I recommend here is to check your ultrasound machine as a part of quality control to see which formula does your machine use. International guideline using Delphi consensus suggests that the the best formula is the Handlock formula that accompany the AC, HC, and FL only. So from this formula, I think this is Handlock 3 formula. So Handlock has 5 formulas, 1, 2, 3, 4, and Handlock only. So the Handlock formula accounts only the HC, AC, and FL apart from the PPD, because PPD is much affected by the hair shapes like dolichocephaly or brachiocephaly hair shape. And those hair shapes, if the fetus has those hair shapes, it will affect the overall estimation of the estimated fetal weight. So the most recommended formula is this, and a lot of scholars agree on that. So what I'm suggesting for you all is to go into your ultrasound machine setting and to see which parameter does your ultrasound measurement used to estimate the estimated fetal weight. Okay. I tried a lot of measurements, and there is a huge difference in using the same biometric measurement. There is a huge difference in obtaining the estimated fetal weight. So as a part of quality control, you should always check which formula does you use. The recommended is Handlock only formula from PPD. So we have the exact gestational age, we obtained the ultrasound biometry. So what's left? We have to check those parameters respective of those exact gestational age. So I know that there is a lot of growth charts available on internet, but the most recommended growth chart that I recommended is Intergrowth 21st Century research, which was taken account of a lot of population data, which are highly on methodological. But what guidelines recommended was formulating nationally or locally mandated charters. At Ethiopia, we don't have any nationally or locally mandate charters, for my knowledge. And I want to recall the Ministry of Health and other policymakers to initiate such population data and to do researches on those individuals and to finally formulate a nomograph that was tailored for a local context. It's a paramount important. The reason behind this is the intergrowth 21st century growth chart. The reason that I use this chart is in his methodological part, it accounts the nearby region like Kenya and South Sudan. So those individuals have similar growth potential like our countries and nearby countries, the same weather, the same population. So, and it's the best apart from the others. The others, if you use the other charts, you may end up calling every fetus here in Ethiopia. For example, if you use a chart that's being used in America, you may end up calling all fetus in Ethiopia as FGR or SGR. So it's really paramount important to select the best charts that could be tailored with your nationality or your your tailored growth potential. Okay. So technically, after this point, we can diagnose small for gestational age. We have the exact gestational age, we have the biometry, and we are going to compare those exact gestational age with the biometry. If it is less than, for example, if you take 30 weeks, if it is less than with 1.1 kilogram, so it's a small for gestational age. It could be growth restricted, could be constitutional normal, but we all know for the fact that it is small for the exact gestational age. So there are different types of small for gestational age. The first thing is asymmetric SGA. So BPD is normal, HC is normal, AC is decreased, D means decreased below the 10 percentile for the exact gestational age. FL is normal, so if estimated fetal weight is decreased, we can call it asymmetric small for gestational. If HC and BPD is decreased and the other parameters are normal, the estimated fetal weight could be normal or the estimated fetal weight could be below 10 percentile. So if it is below 10 percentile, we call it asymmetric. For asymmetric, we can call it asymmetric SGA. Now, you may question to me that the hair parameter is decreased, so this case is not SGA, but rather it is microcephalic. But I can tell you that scholars strongly suggest that microcephalic head can be diagnosed if the head is the head centile or the head percentile is below 5 percentile. So if the below 10 percentile and the estimated fetal weight is decreased, it's asymmetric SGA. And we have to also investigate other factors which may decrease that specific or spared head measurement. The other thing is all the parameters, the head parameters and the abdominal parameters are normal, but the FL is decreased. Again, you may also remind me that this has skeletal, this patient has skeletal dysplasia, not NSJ. Of course, it can be. So if skeletal dysplasia like achondroplasia or any other skeletal abnormality, mesomelia, or any other thing can be diagnosed if the FL is below 5 percentile, and when we calculate the weight, it could be decreased below the 10 percentile, or it could be normal. Decreased, we call it femur sparing SGA. It's another phenotype of small for gestational. The symmetric one, or the biometric measurement, including the estimated fetal weight, will be decreased. So, until now, we were talking about the size, not the growth potentials of the fetus. We don't know the growth potential of the fetus yet. So, if the fetus is below 10 percentile in size for the exact gestational age, we have to look for the possible growth restricted pattern, okay? So for diagnosis, different guidelines recommend the fetal growth velocity, the customized growth charts, which takes account of the maternal factor, like the maternal weight, the maternal length, because it's genetically predetermined. So a lot of ultrasound machines also have a slot for entering the mother's kg, the mother's head, but I found it's not that much practical, especially in our setting in which you can do 60 up to 30 patients per day in the hospital setting, so it's not practical. So our main focus for diagnosis of FGR here would be the fetal growth velocity and the Doppler velocimetric evaluation. The use of biometric biomarkers like placenta growth factors is beyond the scope of this lecture. So if you use fetal growth velocity and Doppler velocimetric evaluation for diagnosis, so for monitoring purpose, usually it's recommended to do umbilical artery in weekly or monthly fashion, and biophysical profile also helps us to monitor those patients which were previously suspected or confirmed for FGR. Biophysical profile is not a diagnostic tool for FGR patient, and you should also know. So, diagnosis tools for fetal growth restriction. The first one is fetal interval growth, what we call fetal growth velocity. It's a trajectory, so fetus that are deviating from their individual trajectory indicating a failure to reach their growth potential. So statistically, let's put that statistically. So if you measure the fetal size and you found the fetal size to be, let's say, 80 percentile for the current gestational age, if we say this, and after you obtain the same fetus after 2 weeks, maybe 2 weeks or 1 month, and if you found that fetus to have a percentile of 20, there is a difference, 50 percentile difference between the ultrasound that was done now and after some time. So if it is above 50 percentile, if the difference of those percentile is above 50, then that's the criteria for calling a fetus FGR. The other thing is a change in Doppler velocimetry. So there are 4 vessels specifically that was used to diagnose FGR. The first one is uterine artery, umbilical artery, midcellular artery, and ductus venosus. So let's continue with the uterine artery. In uterine artery, if the mean PI is greater than 95 centile, that means there is maladaptations of the placenta, or there is abnormal trophophilus invasion, and there is defective placentation. Indicates all this. It also indicates a maternal vascular malperfusion of the placenta, hence there is no oxygen or nutrients for the fetus, so that fetus is tended to be growth restricted. The main thing here is I call it mean PI, and a lot of guidelines also emphasize on it. It is to refer that you have to obtain the PI value of the uterine artery from the right uterine artery and the left uterine artery. Then you have to combine those measurements to obtain the mean PI, and mean PI is a recommended indices to diagnose any defect, any changes in uterine artery. The other thing to consider, especially when we do uterine artery in the second and third trimester, is to check the placenta location. If the placenta is anterior and posterior, that's okay. That's okay. That's no problem to identify and to check the mean PI. But if the placenta is lateral, it could be right lateral or left lateral. So when you measure, let's say the placenta is right lateral. So when you measure the left lateral sides of the uterine artery, it could have a resistance because there is no so much trophoblast invasion as on the right side. Okay, so that alter your Doppler reading to be a resistance vessel rather to be a normal vessel. That is why calculating the mean PI is important in assessing the uterine artery. This is one reason to assess the mean PI. Not only the indices, but we could also assess the waveform of the uterine artery by using qualitatively. So decrease in diastolic flow or notching is associated with placental insufficiency or associated with higher resistance. Okay. The normal waveform is this one, especially on the second and third trimester. And when the fetus reaches the third trimester, the diastolic flow will eventually begin to increase here or here. This waveform is abnormal if we found it on the second and third trimester. This is a waveform of umbilical artery, which could be normal if the mother is not pregnant, and which could be normal if the pregnancy is below 10 weeks of gestation or 12 weeks of gestation. But after that, we are not expecting the notching, which will be seen in early diastolic flow here. So eventually, as I told you before, the pregnancy progresses, the diastolic flow will eventually become higher. Let's talk about the indices. As you all know, when you do Doppler ultrasounds of the umbilical artery, uterine artery, and mid-cerebral artery, there are indices which are indicated on the sides of our ultrasound screen. And the common indices are systolic to diastolic ratio, pulsatil index, RI, and other parameters. So resistive index and systolic to diastolic ratio are easy to interpret, but it doesn't recommend it to diagnose FGR. To diagnose FGR, if it is arterial flow, so the most recommended indices is the PI value. So as I told you in my previous lecture, you have to check whether the PI is calculated based on TM max or TM min, because the two parameters are different. If the PI is calculated, the formula for PI is systolic minus diastolic over time average maximum velocity or time average mean velocity. So you have to check whether your machine was performing on TA max or TA min. Because it may result in different readings of the PI, and the normal graph that you are going to use must also align with your machine settings of using TA max or TA min for calculating PIs, and you also be take care on those differences. Okay. Okay. Nice. The second artery that The second artery that we are going to discuss here is umbilical artery Doppler. So we can assess the umbilical artery Doppler qualitatively and qualitatively as we do on uterine artery. So qualitatively, it's represented as absent in diastolic flow, and in most severe cases, it could also be reversed. So the normal waveform is actually, I was arguing with my friends about this waveform, and he said that do an umbilical artery waveform, and if you found a diastolic flow, which is here, then consider it normal. If there is a diastolic flow, consider it normal. Don't calculate the PI and other parameters. But that's not true. Even if you see a diastolic flow, it could be reduced, and this could indicate the early manifestations of placental insufficiency or afterload or increase in resistance. Okay, so the most recommended thing is to use a PI, even if the waveform have a diastolic flow, the PI could also be above 95 percentile. So if the PI is above 95 percentile, that have to be considered as an abnormal uterine artery, umbilical artery flow. This is diminished. There is no diastolic flow here. Only the systolic flow is displayed here. And in most severe cases, you can also see a reversal flow down there. So that's the qualitative approach, but quantitatively, the uterine artery PI, you have to check on your graph after calculating and after obtaining a result of those PI, you have to check the centiles of that PI for that established gestational age that we are established in the previous slides, okay? What I call that a pivotal, not only for sizes, it's also used for estimating or knowing the centiles of the Doppler indexes. So if the uterine artery PI is greater than 95 centiles, it's associated with placental insufficiency. So it indicates increased fetal afterload resistance and a decreased placental surface area available for gas and nutrient exchanges. And the graph is here. The red indicates as 95 percentile, the other is 50, and 5 percentile is illustrated here. So at this time, you may call it that, oh, Teddy, this is a boring thing. You see, there is a hassle obtaining the biometry, obtaining a gestational age, exact gestational age, and then you go to the graphs of the fetus, then you obtain the fetal size to be below 10 centile, then you are going to do a Doppler for those arteries. After you obtain those arteries, there is still a work to do, and there is taking a graph again. So that is a boring. You may call it boring, but the most important thing is it is associated with severe neurological and metabolic disturbance for the fetus, as well as it may result in stillbirth. With that being said, to decrease the workload, I will provide you a very good trick. So you can see that there is a 95 percentile, the lowest 95 percentile is indicated in 40 gestational age. This is the exact gestational age that must be established before doing anything. So if you take this line, the lowest PI value is around 1.1. So what I'm gonna tell you is do a Doppler of umbilical artery or any other artery. If you found a PI index of below 1.1, irrespective of the gestational age, then don't check the graph. It's normal. It's always normal, irrespective of the gestational age. But if it is above 1.1, it could also be normal if it's like beyond here and here. So it's time to check the graph and to obtain the exact centile for the specific artery under investigation, okay? The same is true for middle cerebral artery, but middle cerebral artery is the reverse of umbilical artery. Middle cerebral artery is logically a high resistance flow because the baby is in the good shape, the baby is on the uterus, he has nothing to think about, he has nothing to think about the life hassles, so it doesn't need any blood in the brain. It doesn't need anything to think about, okay? So normally it is high resistance flow, okay? But when the FGR strikes out, he has a lot to think about. So the flow will eventually go up to the coronary artery and the brain. So there is a vasodilation takes place. That's what we call a brain sparing effect, because there is a preferential distribution of blood to the fetal brain, because he has a lot to think about. And it will be displayed as a decrease in resistance. The diastolic flow will be increased. The pulsatility index will be decreased. And if that pulsatility index is below the 5 centile for the established gestational age, so we can call that abnormal middle cerebral artery PI, or abnormal flow in middle cerebral artery. This is commonly associated with asymmetric SGA, in which the AC is below the 10 percentile, but the brain is normal for gestational age. The same trick applies here. So the 5 centile, the lowest possible 5 centile is here. So it's around 1.7. So if you found a middle cerebral artery, and if you found a middle cerebral artery PI above 1.7, don't check a graph, it's normal. But if it's lie on the periphery, in which there is a high metabolic rates here and here, so it could also be normal if it is below 1.7, but you need to check the graph. I almost decrease half of your workload, okay? This is how to do an umbilical artery, a middle cerebral artery, sorry. So zoom in must be takes place. Let's say Doppler gauge here in the proximal portions of the middle cerebral artery, apart from internal carotid artery. Then you have to decrease the gain. Did you see when you decrease the gain, the Doppler gauge? So he decreased the Doppler gauge, mapping of the proximal part, best site and best technique. So the waveform outline, almost 75% of the screener state. This is the high resistance flow. This is the high resistance flow. You see the low diastolic as compared to the systolic. It is normal for a fetus, the unaffected fetus, okay? Ductus venosus, the best view to map ductus venosus is in transverse abdominal thoraco oblique, okay? Here the lung is seen because it's oblique, and the abdomen is here, and you will map the ductus venosus right above here at a point where the color lensing happen, decrease again, and mapping the ductus venosus as he entered into the diaphragm, then eventually to the IVC, okay? So the normal waveform of the ductus venosus looks like this, and the gestational age increase, those diastolic components will become higher, okay? Decrease the baseline, and the scleral state will not be that much complex, okay? So most of the time, we don't quantitatively assess the ductus venosus. It's all about qualitative assessment of the ductus venosus. Actually, the qualitative PI, ductus venosus PI, will be altered before you see qualitative waveform changes. But usually this is used in late FGR formulas, so most of the time we are going to focus on the qualitative approach. So talking about the ductus venosus usually require the whole lecture, so let me recap it shortly. This is systolic flow. Ductus venosus is already associated with the arterial flow. If there is a high resistance in the atrium of the fetus, then the ductus venosus will be decreased. But if there is a low resistance, the ductus venosus waveform will be increases. So based on the cardiac cycle, the S wave, V wave, a certain deceleration here in the late systole. Late systole is indicated by V wave, and systolic upstroke is indicated here. And then the atrium will be filled with blood. When the atrium filled with the blood, then the resistance develop. So it's indicated as here, which is technically early diastolic flow or passive diastolic flow of the atrium. But after a passive diastolic flow, usually in the cardiac cycle, the atrium will eventually pop out forcefully the blood which is remain on the atrium to the left ventricle. So when it pop out actively, it requires a conduction system. So it squeezes forcefully. When it squeezes forcefully, the air waveform will be eventually decreased because there is significantly high pressure, unlike the deceleration in S wave. There will be significant decrease in the ductus venosus waveform. That's the basic pathophysiology of ductus venosus waveform. It's a normal ductus venosus waveform. There is no that much hassle. There is no that much pulsatility. But when FGR strikes or when there is any abnormality that happen in the fetal heart, the ductus venosus waveform began to change, as you can see here in the absent A waveform, or in the severe case, the A wave would be reversed. So when we talk about A waveform, the abnormality solely in A waveform, we are talking about abnormal late diastolic filling. But A waveform is not the only parameter that changes when the abnormality strikes. But if there is a high cardiac output that encountered on the fetal heart, then the V and the D also will be altered sequentially as indicated here. At the last, not only the diastolic, but also the abnormal, the indiastolic or V will be abnormal, early diastolic will be abnormal, and A waveform will be also abnormal. So different scholars hypothesize the change in ductus venosus waveform. So the first one is hypothesized that it's due to the progressive dilation of the ductus venosus isthmus. So to accommodate for the lack of oxygen, the ductus venosus, which is a primary source for oxygen in the heart and myocardium, the duct or the isthmus or the pipe will be dilated. That is what it creates the changes in waveform. Okay, this is the first hypothesis, and the second is the most plausible hypothesis. During brain sparring effect, let's say brain sparring effect or ACGR, there is a high cardiac output to compensate for the lack of nutrition and the lack of oxygen. So whenever there is a forceful contraction, then the atrial pressure will be increased. If it is increased, then the ductus venosus will be altered. Usually, the intra-arterial pressure is due to the increase in cardiac afterload, mostly commonly due to the placental problems. The other also hypothesis that during the end stage, there will be fetal acidemia or myocardial cell function alteration, okay? So if the heart muscles lose its compliance, so it becomes stiffness, and if there is a stiffness, there is increase in pressure in atria, so there is eventually consequential alteration in ductus venosus waveform. We are finishing our lecture. The most important parameter is CPR in diagnosis of in Doppler diagnosis of FGR. Why? Because CPR accounts the variable of MCAPI and uterine artery PI. Okay, CPR could be abnormal if MCA is normal, but in the borderline, and if umbilical artery is abnormal. CPR could also be abnormal if MCA is abnormal and uterine artery PI is normal, but within a border range. And surprisingly enough, it could also be abnormal if both parameters are normal and but within the borderline stage. That's why it's the best tool for diagnosing, for Doppler diagnosis of FGR, because when FGR strikes out, especially in the late phenotype of FGR, CPR might be the only chance to be altered early, okay? Because the time it takes for changes in late FGR is as rapid as anything possible. But when you consider early, it gives you some time to diagnose, or it gives you some time to, there is a cascade of alteration, okay? So CPR, due to this factor, CPR is the most important parameter to diagnose, to early diagnose FGR, and it's the best for late onset phenotypes of FGR. It's the most sensitive parameters for fetal hypoxia. As I told you, even if the MCPI and the uterine artery PI is normal, but within the borderline range, so CPR may be abnormal, okay? Different scholars strongly associated, suggest that it's strongly associated with adverse prenatal outcome than the sole use of uterine artery PI or MCAPI. So consider CPR ratio when dealing with FGR, especially the late phenotype. Let's summarize the Doppler velocimetry data, and let me give you some chit chat that I was proposed earlier. So do the 3 vessel Doppler. So if you found the uterine artery PI less than 1, and if you found MCAPI greater than 1.7, which is the 5 centile, if you found CPR ratio to be 1.7, as indicated here, the lower margin is here, and 1.5 around this is a 1.7. So anything above this is below the 5th percentile, as indicated in the red line. So if CPR is greater than 1.7, it can be considered as normal at any gestational age, and there is no need to check the normograph or the data, okay? In any form of FGR, usually the early onset phenotype, there is a cascade of velocimetry change. So the first one to be altered is uterine artery PI. The second is cerebroplacental ratio. Here, the third is the diastolic flow will be qualitatively absent. If it progresses, it will go through reversed here. Then the aortic isthmus and the ductus venosus PI will be altered before the A wave or become absent or reversed. The aortic isthmus is usually a forward flow, but if you found a retrograde flow in aortic isthmus, then that indicates adverse prenatal outcome. Prenatal direct. Then after that, the umbilical vein, which was a mono waveform, will become a pulsatile. After that, biophysical profile change will be occurred. Finally, fetal acidemia and stillbirth will occur. This is a cascade of changes in FGR. So we finished diagnosis. So we know that the fetal is FGR. by using those parameters. How do we monitor those FGRs? So the first thing is that we commonly use is biophysical profile. So biophysical profile is not used for diagnosis of FGR, but it would be beneficial for monitoring. So the two proposed assessment of biophysical amniotic fluid index. Amniotic fluid index is one of, as you all know, I don't want to discuss the other parameters of biophysical profile because it's beyond the scope of this lecture. So let's only focus on amniotic fluid, which is one parameter of the biophysical profile. So AFI and single deepest pocket is proposed. AFI is usually better for polyhydramnios. The single deepest pocket is usually proposed for oligohydramnios. And if the single deepest pocket is less than 2 centimeters in transverse and longitudinal direction, then that may be confounding in FGR fetus, and you should assess if it is less than 5 centimeters for the given gestational age as indicated on the graph here. So if there is oligohydramnios, it's usually indicated there is an impaired placental function or renal perfusion. It's my last topics of FGR. After we diagnose FGR, we have to know that there are two types of FGR. There are two phenotypes of FGR. Those early onset FGR and less onset FGR are the two phenotypes of FGR, which is usually differ in their clinical appearance in ultrasound characteristics and the gestational age in which they will be takes place. But usually in the Delphi consensus criteria, the experts were gathered and they usually agreed that a 32-week cutoff will be used to delineate early onset FGR from late onset FGR, because they do have a different pathophysiological pattern, a different management, a different things, okay? So in early onset FGR, it's usually due to placental insufficiency, okay? So elevated Doppler umbilical PI, Doppler umbilical artery PI precede a cascade of Doppler alteration in early onset of FGR. So when it becomes to deteriorate more, you will see the reversal of in-diastolic flow, and when there is a general cardiovascular and metabolic failure, the ductus venosus will be affected in early onset of FGR. The late onset of FGR is so much difficult, and even scholars don't understand the full pathophysiological patterns of late FGR. It's characterized by milder and more specific placental lesions and or alterations in oxygen and nutrient diffusion. So in this late onset of FGR, the strike is rapid. For example, you may do biophysical profiles at today, so it becomes normal. Then the late onset FGR may strike days later or weeks later. So biophysical profile is not a benefit here, but also Doppler, umbilical artery Doppler and venous districts are also rare to be changed in late onset FGR. The only option in the Holy Grail for Doppler investigation of FGR is CPR ratio. So CPR ratio can detect a subtle change in umbilical and cerebral blood flow before fetus were actually restricted. So CPR is of paramount importance in diagnosing late onset FGR, which were usually above 32 weeks, okay? So Delphi consensus in 2021, Delphi means a collection of experts. The experts would be gathered and they will deal with a lot of matters, but the matter was usually a more controversial matter. So they gathered information, they analyzed a lot of meta-analysis and a lot of researches. So they eventually produced a data which was consensus, which they reach a consensus of. Okay. So as I told you before, they classified the two, early FGR and late FGR. So this is the guideline that I use throughout my daily practice. And this is my last, these two are my last slides. So I'm going to walk you through the final diagnosis of FGR based on ISO criteria for FGR diagnosis. So in exact day, you know that the fetus is less than 32 weeks, and in the absence of congenital anomaly, if you found when you measure the fetal size, if you found the AC to be less than third centile, you can call it that fetus FGR without considering Doppler parameter, growth velocity parameter, and other things. Not only for early FGR, but also for late FGR, if you found the AC or estimated fetal weight to be below third percentile for the very established gestational age, you can call it FGR straight away without considering or without hassling any graph, any normograph, or any other things. Okay, that fetus, if the fetal size is less than third centile for unestablished gestational age, that fetus was indeed growth restricted. Okay, no need to hassle other things. Or if the fetus is below 32 week, you may conform it by another parameter, or you may not have any established gestational age, but you certainly know that the fetus is 32 weeks, and when you do umbilical artery Doppler, if you found an absent in the diastolic flow, without considering the estimated fetal weight, without considering the AC, if the umbilical artery display qualitatively an absent in the diastolic flow, you may call that fetus FGR right away without considering the thing that we talking about before. Okay, that's the beauty of consensus. That's the beauty of defining a criteria. Or if AC or estimated fetal weight less than third percentile combined with uterine artery greater than 55 percentile and or uterine artery PI, umbilical artery PI greater than 95 centile, you may call it FGR fetus. Okay, so when you do umbilical artery or estimated fetal weight, you may find the size to be less than 10 centiles. And what you're gonna do is you are going to investigate the Doppler. So if the uterine artery and the umbilical artery was found to be greater than 95 centile, you may call it FGR, but in combination with Doppler parameter. Okay, if the estimated fetal weight or the AC is less than 10 centile for the established gestational. But in late FGR, which was considered above 32 weeks, the AC, something was changed on diagnostic criteria. So I told you before that whether it is late or early phenotype, if the AC or if the estimated fetal weight solely become less than 30 percentile, you can call it FGR straight away without considering anything. But in late FGR, if the AC or estimated fetal weight was less than 10 centile, so okay, at least two criteria must be fulfilled to call the fetus late FGR. The first is the AC or estimated fetal weight must be less than 10 percentile, or in combination of one or the two, okay? The AC or estimated fetal weight crossing a centile greater than 2 quartile, which I have told you before. If it is less than, if it's greater than 50%, the difference between the first ultrasound and the second ultrasound centile was greater than 50 centile. That indicates FGR in combination with AC and estimated fetal weight less than 10 centile, or if the CPR is less than 5 centile, or the uterine PI is greater than 95 centiles, okay? So at least 2 of the 3 criteria must be met for late FGR. If the centile is greater than 30 percentile. At this time, you may see that the AC or estimated fetal weight might be greater than 10 centile, but if the AC and this estimated fetal weight interval growth is greater than 2 quartiles on the growth centile, and if the CPR is less than 5 centile, then even if the fetal size is appropriate for gestational age, that fetus was FGR and it was masking on its appropriate fetal size, okay? So the recommended reference chart is the intergrowth uniform first charts. Again, for the Doppler parameter indicates those centiles and the PI value. This is the most recommended one, and I will happily provide you the material that I use in my daily lives, okay? So there are pitfalls in growth assessments of FGR. The first one is you call it SGA, but the fetus might be constitutionally small fetus, and rather it will be normal, okay? So you may consider that. Incorrect dating, and the other is chromosomal and structural abnormality may be a pitfall in diagnosing FGR. Monitoring and management, antenatal surveillance, which include non-stress tests as a part of biophysical profile, which will help in timing and the mode of delivery, okay? The frequency of ultrasound surveillance, depending on the severity of the Doppler finding, as well as the phenotype of FGR. You don't manage the late FGR as you manage the early FGR. So those surveillance frequency or ultrasound frequency will be different for the two phenotypes, okay? We discussed this. Neurological development sequelae will happen in long term, and metabolic and cardiovascular disorders in adulthood will happen, even if the patient was delivered normal right away, okay? So that's the importance of early intervention and follow-up for FGR fetus. That's the most pivotal. You may be the fetus as well as the mother may be benefited by some medication. It may be steroid, corticosteroid may be helped. But the paramount importance is because you diagnose the fetus to be FGR in prenatal period, you may benefit the fetus not only on the prenatal period, but throughout his life, okay, after the delivery. This is the end of my lecture, and I'm going to conclude the lecture with 2 case studies. So my first case study is a 28-year-old preeclampsia referred at 32 weeks for suspected IUGR. So we consider this as early onset. The estimated fetal weight is less than 5 centile. AC is less than 5 centile. The amniotic fluid is 4 centimeter. Then it's already small for gestational age. Then we do the Doppler. So when we do the Doppler, we found increased resistance in umbilical artery, which was found to be above 90 centile for PI. And the MCA Doppler is decreasing resistance. This is the brain sparing effect. This is a FGR patient because it fulfilled criteria among the 3 identified criteria, okay? The Doppler 1 and the estimated fetal weight and the AC1, okay? According to the Delphi consensus and published by ESOP in 2021. So As a management, this patient was delivered at 34 weeks by cesarean section, and the birth weights were found to be 1.3 kg, and it was a good outcome. The second case study was 35 years old, multiple gravida, referred at 28 weeks for suspected IUGR, and considered this as early FGR. So the estimated fetal weight was 800 gram, which was less than 3rd percentile for gestational age, and that's enough for most of us, because if you found the estimated fetal weight, even the estimated fetal weight alone, or the AC alone, if it's found to be less than 3rd percentile, this is FGR patient. So the uterine artery is Doppler is absent, diastolic flow was demonstrated, MCA decreased resistance, and there is an increase in pulsatility in ductus venosus Doppler. So the best management was delivery, okay? But when we consider early onset FGR, we should always consider the benefit of delivery with the prematurity of the fetus, and the institution. We should also consider the institution that if we have a fully equipped NICU, 30-week fetus may be normal after delivery. Okay, so when deciding a management option or delivery option, it must be weighted the benefit with the prematurity and the IUGR. So that is all. Thank you so much. This is all about FGR, and after this, I'm expecting a hot and intense discussion, and your question is welcomed. Thank you so much for all of you, okay?
Thank you so much, our presenter. That was really a good presentation. I followed through, and certainly I've picked out some points for my own notebook and for my own practice. So I think right about now, we'll go straight into